Thanks for such a warm welcome, and also thanks to Joe for the invitation to speak to you here this evening. There are obviously very well documented problems facing our health service, but I'd like to start this evening with a positive or a hopeful story, and that is the centralisation of cancer care. This is widely regarded as one of the success stories of the Irish Health Service. The move was initiated by Mary Harney, who was the then Health Minister, back in 2007, and it was a watershed. Doing the right thing was very hard for Harney, even though the Cancer Society pointed out that a centralised approach to cancer care can improve our outcomes by as much as 20%. There was huge local opposition to the closure of services at hospitals or at local hospitals. Thousands took to the streets in Mayo, Sligo, Kerry and elsewhere. Many politicians dutifully attended the protests in their constituencies and weighed in. Harney appealed for cross-party agreement on how to improve cancer care, but instead she confronted a no confidence motion in the Dáil. The health service pressed ahead, and Professor Brendan Drum, who was the initial head of the HSE, subsequently said that that move simply would not have happened without the huge political backing that Harney gave to that plan. She took the heat for the health service. But the health services continued to face massive resistance to any centralisation of hospital care that involves the closure of local services. Frank here just referenced Portlaoise Hospital. The public still wants hospitals to be all things to all people. Senior health management believe we have far too many acute hospitals providing complex care. Replacing or replicating and staffing acute care rosters in all of these hospitals is hugely expensive and wasteful. In fact, it's become so difficult that we're now having to staff them with non-specialists, which is not ideal from anyone's perspective. The Association of Emergency Medicine, which represents doctors who actually work in our emergency departments, has been telling us for at least a decade, we have too many, we don't need this number. In Dublin alone, we have 9 emergency departments. For a city of our size, that's actually unheard of. The failure to centralise care means many smaller hospitals are continuing to do things that they shouldn't be doing, even though it's unsafe to do so. Take trauma. Last year, Surgeon David Moore highlighted how patients with broken bones were being brought by ambulance to 26 hospitals across the country, even though 10 of these hospitals didn't have orthopaedic surgeons on site. That's actually incredible when you think about it, because it means that people are arriving with broken bones and nobody can fix them. All it was doing was simply delaying their care and resulting in poorer outcomes, especially for the elderly. The failure to make these hard decisions on issues like this is part of the reason that we're not getting value for money in our healthcare budget right now. These are political decisions, and they're costly decisions. Some of those working in the health service, I'm just going to make sure my slide. Some of those working in the health service feel the criticism, or what they feel like the constant criticism of what's happening in the health service is excessive, undeserved and sensationalised. Sometimes they make valid points, but when you actually look at what's happening and how we compare to other countries, it's hard to feel that we're getting bang for our buck. Despite having one of the highest proportionate spends on healthcare in the EU, we have a public health system that is blighted by poor access and outcomes that are inferior to those of many of our neighbours. Just to give you an example, when Fine Gael and Labour took office in 2011, we had about 9,000 patients waiting longer than 6 months for scheduled or planned care. Today, as you can see, that figure now stands at about 35,000. There's been a very small recent drop, but you can see where the trend is going. As I say there, you don't need to be a statistician to see it's not a good picture. But let's just put that in an international context. England has a population of about 53 million. It has a target to treat 92% of patients within 18 weeks. And despite the headlines you read in many of the different British newspapers, they actually meet that target most of the time. Ireland has a population of 4.7 million or so, and we talk about targets of 18 months. There's no other country in Europe that refers to a target of 18 months. We're an international laughingstock. In Ireland, we have 13,787 patients waiting longer than 1 year for treatment. Just look at the figures for England, despite their much, much greater population size. The NHS is not some sort of utopia. It's actually not a model that I'd advocate that we follow. But they're doing a much better job than we are, despite spending a lot less. There are difficulties in accessing GPs in the NHS system. That wasn't a problem here, but it's now becoming a problem. GPs are closing their clinics to new patients, whether those patients are medical card holders or private patients from whom typically GPs will earn more revenue. Access is a major problem, and as I mentioned there, it cannot be explained by what we are spending. This is, or was, I should say, how we compared in 2016 in terms of our per capita spend. It's hard to actually dig out, I realise, in the graph there to see it. So I got provisional figures from the OECD for 2017 that haven't yet been published. We were the third highest per capita spender on healthcare in the EU. You can see there the only country that spent more than we did was Germany and Sweden. Austria and the Netherlands were also high. Isn't it ironic? The Netherlands was the very system that we felt we couldn't afford to emulate. This is all the more surprising, given that we have a comparatively young population. Healthcare expenditure increases as we age, so because we tend to develop more chronic conditions and have more comorbidities. There's been a lot of criticism from people working in the system about these figures, and something that I hear constantly as a journalist, oh, but this is we've only started spending a lot of money in recent years. Historically, we underspent. Well, actually, we didn't. We have been a consistent high spender on healthcare. You can see the figures going back as far as 2008, where we were one of the highest, and 2012. So this isn't just a new phenomenon. And yet, our outcomes, though they're improving, are not exceptional. I discussed earlier about breast cancer or cancer care and the centralisation of cancer care. That really has delivered improvements in our outcomes and survival rates. But boy, was it needed, because we were down near the bottom for very, very many cancers. And sadly, we still are, even though our outcomes are improving. Take breast cancer mortality. Ireland had the highest death rate in the EU from breast cancer. Similarly, our 5-year breast cancer survival rates is lower than that of the vast majority of our neighbours. When you look on at colon cancer, those survival rates are also one of the lowest in the OECD. The picture isn't all that much better for stroke, although it is improving. As a nation, we're investing a considerable amount of money, and yet we don't have an accessible system or enviable outcomes for very many common diseases. In recent months, I've watched on or looked on as Taoiseach Leo Varadkar and Pascal Donoghue have referenced our high spending, and they've done this, I suppose, and used it as a tool with which to beat the health service. I presume the spin or the idea behind this is to say, blame health service management for everything that's going wrong. Don't get me wrong, I have a lot of problems with health service management and the way the health service is run from within. But we rarely actually examine the role that politicians play in our dysfunctional system. Look at the number of government-commissioned reports that have gathered dust under various administrations. We've been talking about shifting primary care or moving chronic care into primary care and the community or out of hospitals since 2001. That was when Micheál Martin launched a primary care strategy. It hasn't happened. There's no sign of a new GP contract. There's various other reports. Reach Out, the National Suicide Strategy, didn't happen. A Vision for Change for mental health, numerous recommendations, didn't happen. A National Carer Strategy, no sign of that happening either. We've messed about with structural reform. The current flavour of the day, as Frank said there, is Sláinte Care. Though the reality is nobody thinks it's going to materialise anytime soon. The mood music from government is, it's too expensive and we're spending too much money. This has been a long-standing issue and problem in the system or the health service. If you think back, and many of you will remember this, in 2010, Fianna Fáil was pursuing a policy of hospital co-location along with the Progressive Democrats. There was a lengthy tender process, and some consortia even went so far as to apply for planning permission. Then Fine Gael and Labour came to power. the co-location plan was axed, and there followed the saga of Fine Gael and Labour promising to deliver universal health insurance. They did that without doing their homework. Then the ESRI came along 5 years later and said, it's too expensive, it can't be done, and that was dropped. Fine Gael also abolished the board of the HSE, a €14 billion organisation in 2011, because at that time it was also planning to scrap the HSE. Well, guess what? Here we are, 7 years later, and the HSE is still with us. Then Fine Gael and Labour established hospital groups as a precursor to so-called hospital trusts that we were all going to see. The trusts never materialised, but we've a whole host of new management at the senior upper echelons within the health service. Some of our high spending is directly attributable to political interference and in some cases political apathy. Politicians regularly force the HSE to fund expensive drugs that are not considered hugely effective or in fact effective at all. This is something that transcends political party boundaries. Everyone in opposition does it. It's partly, I think, the media has some culpability in this because we tend to run a simplistic narrative where we interview super responders to certain drugs who really aren't representative of the norm. You rarely see a media report in which the actual details of the clinical trial are reported clearly, where it says this actually resulted in an improvement in outcome of, say, 3% in lung function, which was actually the reality for the cystic fibrosis drug, or Cambi, that we heard so much of recently. Public pressure mounts, and as I said, the opposition politicians make hay. But the problems we face aren't just about structures or knee-jerk decisions. Even basic promises aren't delivered. You know, there's been a lot of criticism, and we heard this morning Vicky Phelan and Stephen Teep discuss difficulties with the legal system, especially Vicky. We have an adversarial system where it's all about denying and defending and proving or attributing and proving blame. It's horrible for patients and families as the process is nasty and protracted, but it's also corrosive to the relationships between the health system and patients. In New Zealand, patients seek compensation for medical injuries, not through malpractice suits, but through no-fault compensation systems. Injured patients receive government-funded compensation and claims are processed within months. Nobody is dragged through the court system and nobody is waiting years for redress, which we've all seen cases of families that have been affected by, these catastrophic birth injuries. This is a major, major issue. But our system is also ferociously expensive. We're all footing the bill for this. The claims are managed by the State Claims Agency, and it recently reported that our estimated liability for claims is now 2 billion, up from 1.1 billion in 2014. And you'll see on that slide there's some general, which are non-clinical claims, but you'll see the clinical claims, a huge rise, not just in the number, or not necessarily in the number, but in the actual amount paid out. Much of this money, as I mentioned there, is on maternity claims. But Irish legal costs are also far higher than they are anywhere else in the Western world. The Programme for Government committed to establishing an expert review group to examine this. We will tackle the rising cost of claims by establishing an expert group to report in 6 months, it promised. It actually took cervical check, public pressure for the present government to even set up a review group. That's 24 months or so after that promise was initially supposed to have been delivered. What apathy, given the public or the heartache that these families go through and the enormous costs to the system as a whole. Imagine what this money could be used to do in other areas of the health service. I've spoken a lot about holding our politicians to account, but our politicians are our elected representatives. We spend a lot of time examining what the health service and government are doing or not doing to our satisfaction to improve things. But we spend considerably less time looking at what we as potential patients and indeed voters could do differently. What about personal responsibility or accountability? At a very basic level, consider the number of people who do not attend hospital appointments they have been given. Those working in the health service use the acronym DNA. Every year, hundreds of thousands of patients simply fail to show up with no warning, even though we're all aware of massively long waiting lists. Some of these patients who don't show up obviously have legitimate excuses, but personal illness and tragedy surely only account for a small number. During a debate in the Seanad earlier this year, Fine Gael Senator Colin Burke described how he had been told by certain hospitals that over the Christmas period, 50% of people didn't show up for outpatient appointments. That results in a huge waste of time and actually exacerbates the waits for others. Of course, it's unfortunately not just a seasonal problem. And you have some figures there for 2017. You can see that it works out, 479,000. It actually works out at 1,842 per day. Tony McNamara, who's the chief executive of CUH, writes a very informative and honest blog. And he described that many people, or he recounted that many people don't show up even after their appointment has been reconfirmed with them. And he put a cost on it, based on a €44 cost. The national cost to all of us of this happening every year is €21.5 million. It would fund the drug that Vicky is currently trying to get, Vicky Phelan, for many patients with cervical cancer. It would fund a lot of home care packages. Writing in the Irish Medical Times, Dr. Rory Hanley, who's a GP and regular commentator in the media, said he believed that all patients should get a letter telling them exactly how much their appointment in a public hospital will cost and what it will cost if they forfeit it. I agree with him. And actually the Institute of Global Health Innovation at Imperial College in London and the Department of Health in Britain carried out a study into this, whereby they outlined the cost of failing to attend. It reduced the number of missed appointments by a quarter. Perhaps when people are sent details of their outpatient appointments, they should be advised of this. Former Health Minister actually had plans to put the cost of medication, so for example, if you were getting a medication under the drug payment scheme or a medical card, to put the cost of that in writing on the packets. That was another, unfortunately, it never materialised. After her departure, the Department of Health didn't proceed with it. But many don't appreciate the cost of these medicines. And like many countries, we've an out-of-control epidemic when it comes to non-adherence to prescribed medicines. This is 100% preventable by the very individuals it afflicts. And the numbers are actually staggering. There was a report in the Annals of Medicine, a medical publication, and it put it clearly, saying studies have consistently shown that 20 to 30% of medication prescriptions are never filled, but more importantly, that 50% of medications for chronic diseases are not taken as prescribed. It is estimated that non-adherence to medication causes about 10% of hospitalizations in the United States. The cost of that in the US is between 100 billion and 289 billion annually. There are those who believe that personal accountability should go beyond outlining the price or cost in an effort to get people to limit their contribution to healthcare waste. Consider the following. If you have someone who smoked 2 packs a day for 30 years and someone who never smoked but is unfortunate enough to inherit a condition, both are in need of heart surgery, who should be given priority? Should an alcoholic be placed on the liver transplant list, even if they continue to drink against their doctor's advice? Within the field of medical ethics, many have argued that personal responsibility should be taken into account with healthcare policy. Advocates suggest that treatments will be more effective or provide longer-lasting solutions. It is important to say that pre-existing conditions are obviously not the same. For instance, some conditions occur through no fault of the patient, such as congenital heart disease, breast cancer, and degenerative neurologic diseases. But others are controllable, such as cardiovascular risks. Writing in an academic journal, one American cardiologist questioned whether an inexpensive annual government-provided evaluation of various different health stats, such as our BMI, blood pressure, cholesterol levels, should be used or should be carried out each year to examine people's risk and indeed possibly force them to make higher co-payments. For many, the carrot and stick approach obviously raises huge ethical concerns. For example, if you have someone living in a very socio-deprived area with no access to outdoor space, with no money to buy food, can we penalise them for not pulling their weight or managing their health better? But perhaps there is a more nuanced approach, and I'm very close to finishing, Ruth, because I know I'm a little bit over time, that allows debate about personal responsibility behind victim blaming. Germany introduced incentives aimed at individuals into its statutory health insurance scheme as far back as 1989. It has a really good health system. It offers reduced co-payments for dental treatment to people who attend regular checkups. Since then, many other incentive schemes have been launched. Book 5 of the German Social Security Code actually states that people have a responsibility to look after their own health. The topic of tonight's discussion: can anyone sort out the health service? There's a lot wrong from within the health service, but I hope I've made the point here today or tonight that healthcare reform can't just be focused or seen through the prism of there being one Messiah. And it's time that we saw real political accountability and considered approaches to facilitating greater patient accountability. Thank you very much for your attention.